just give it another minute or two. Ready to get started here. There may be a few more people coming into the hall, but it looks like the majority of you are here, so I'm probably going to get started in about a minute or so. Okay, I'll start to begin the next series of lectures here. Rob de Blasi, and what I'd like to speak about now is inhaled medications for mechanically ventilated pediatric patients. Just curious, how many of you right now are providing some form of inhaled medication to your children? And the ones you take care of? I'm just kidding. Okay, good. How many of you are providing inhaled bronchodilators or some other form of inhaled aerosol therapy to kids on mechanical ventilation? On mechanical ventilation. Have you ever wondered where you should be putting that nebulizer? Back at the humidifier, back at the ventilator, proximal to the patient? Do you think it might do more good if you took it out of the circuit and just nebulized it to the air? Well, I've wondered that also. So I think the focus of today's lecture, we're gonna talk about all the different types of inhaled medication that you can provide to patients during mechanical ventilation. Tomorrow, I'll be discussing a lot of our efforts that we've made in applying inhaled respiratory drugs to spontaneously breathing unassisted patients. So today we'll focus just on the mechanically ventilated patients. So there are several different types of inhaled aerosolized drugs that can be provided during mechanical ventilation. And the most prevalent of all of these drugs that we tend to use in the intensive care units is bronchodilators. And most of us in the room understand that bronchodilators will relieve airway obstruction by relaxing the smooth muscle that surrounds the bronchial tubes. The most common form of bronchodilator that we'll use in the intensive care setting is albuterol. As far as mucolytics are concerned, we will typically use mucolytics that are indicated in patients that have thick retained secretions. One of the most common is Dornase alpha, Mucomyst, and we're beginning to use now at a greater frequency hypertonic saline. Hypertonic saline can be very useful in extravasating water and causing shear, disattaching secretions from the mucosal layer so that they can be expectorated a little bit better. In one patient population, cystic fibrosis, that seems to be very useful and can improve pulmonary function tremendously. Sometimes we'll give expensive antibiotics to for drug-resistant pneumonias and bronchitis, and increasingly these days in the intensive care unit, like Jerry Zimmerman mentioned earlier, we're starting to use selective pulmonary vasoactive drugs that can be inhaled, and in many ways they're more useful than inhaled nitric oxide at a fraction of the cost. So we'll discuss a little bit some of the inhaled drugs that we are using in the intensive care setting. So we know what types of drugs that we're going to provide to the patients, but how are we delivering them? Well, there's a number of different ways that we can provide aerosolized drugs. And for those of you that are just entering the room or who have tried to figure this all out in the past, an aerosol really is just a suspended particle in the gas stream. Okay, and that aerosol particle is going to be larger than the humidity or the water vapor that I was talking about earlier. All right, and depending on the particle size, that will determine where exactly that particle is going to deposit in the lung. But ideally, if you want drug to go into the lung, that particle has to be somewhere around 3 to 7 micrometers or microns to be inhaled. Anything smaller, we'll exhale it. Anything larger, then it will get trapped in the larger airways and there'll be systemic absorption of that drug. So as far as delivery options are concerned, there are 3 different ways that we can give inhaled drugs to a patient in the intensive care unit setting. Either spontaneously breathing with a face mask, we can bag it through an endotracheal tube using an inhaler or using a nebulizer, or we could place it inline during mechanical ventilation. So those are really the 3 options. And the different devices that we tend to use The first one is going to be a pressurized meter dose inhaler, mainly to be given with using albuterol. But you should never use one of those inhalers unless you have a spacer. So we're going to talk about spacers here a little bit too. Jet nebulizers or wet nebulizers, also known as small volume nebulizers, those are the ones that rely upon a compressed gas source, somewhere between 6 to 8 liters a minute. And that's going to actually emit not only gas flow but aerosol into the circuit. Now, these tend to work pretty well in spontaneously breathing patients that are unassisted, but when you start discussing invasive mechanical ventilation, non-invasive ventilation, it gets a little tricky now. Because these nebulizers add additional flow to the system, there's the likelihood that you're going to increase pressure delivery, and in some ways you could impact the way that flow triggering occurs in a mechanical ventilator. So we tend to shy away from these forms of nebulizers, especially when you want to give a drug during mechanical ventilation. Ultrasonic nebulizers, not commonly used. They're very expensive. They produce very good particle size distribution within the respirable particle range size. Vibrating mesh nebulizers, they're very much like jet nebulizers or wet nebulizers, except they don't add any additional flow to the circuit. So in babies and in pediatric patients where you're trying to control the tidal volume and allow them to have patient synchronized ventilation, there's no additional flow, so that this has actually been a big deal in the ICU setting for respiratory therapists and physicians, and also for the patients, because you preserve good interaction between the patient and the ventilator. Before, when we were using jet nebulizers, we'd have to turn the flow rate down on the mechanical ventilator because we're adding flow to that ventilator. Or, in some cases, we'd have to sedate some of the kids because they look so poorly when they're getting the nebulizer, but then we started taking them off of the ventilator and bagging that drug into the lung. But in doing that, you risk destabilization. Anytime you remove someone or break the circuit, you now would potentially introduce microbes into that circuit and increase their risk for ventilator-acquired pneumonia. So really, you got to figure out what type of drug that you want to use and try to settle on an approach based on the most recent evidence. So I'll go over that evidence with you. But first, we want to know that in pediatrics, drug delivery to the lung is going to be very small. You start with a nominal dose. You take a dosage and you put it into a nebulizer, or you give them some inhalers, and about 1% of that dose is actually going to make it down into the lung. That's a very small amount of drug. And the reason why some, if not any of this drug makes it into the lung, is because they have itty-bitty airways. They have very small airways, unlike adults who have much larger airways. And because they have small airways and they're breathing at rapid inspiratory times, there's a tremendous amount of resistance. So an aerosol will tend to fall out of that gas stream if it encounters resistance, and it has more likelihood for impaction against the sidewall of a bronchial tube. But also the low tidal volumes and the small FRCs don't allow these babies to get a lot of drug down into the lung. And you can't just tell a baby to take a deep breath and hold it, right? Especially when they're on a mechanical ventilator. It doesn't work. Trust me, I've tried it. But also because you have such a rapid respiratory rate and small inspiratory time, that doesn't allow enough resident time for those aerosol particles to remain in suspension to go down into the lower airway. So you run the risk of not getting a lot of drug, if not any. So when we evaluate all of the evidence, and keep in mind that the majority of the evidence that you're seeing here looking at pulmonary deposition was done primarily taking a drug like albuterol and using radio-labeled isotopes. So basically a small amount of radioactive solution, and attaching that to these aerosol particles and having babies breathe this into their lung, and then they'd come along, radiologists can come along with a gamma camera and basically take a picture and quantitate how much of the drug that actually made it down into the lung. And so based on all of these studies, we don't do this anymore, by the way. Even though inhaled radioisotopes probably only provide as much radiation as an X-ray, maybe even less, we just don't do this research anymore. Rather, we can look at the amount of drug that's found in the urine, or we can replicate these studies using lung models. And so really, lung models have, in vitro studies, have really guided the way that we provide bronchodilators and other inhaled medications to pediatrics. But you can appreciate that In infants and in pediatric patients, somewhere between 0.3 and 2%, this other value here was dealing with larger children between 2 and 9 years of age, but really somewhere between 0 and 2% of the drug that you put in that nebulizer makes it down into the lung, and that's in non-intubated patients. Now, you complicate this process tremendously when you want to deliver inhaled medication to people that are receiving mechanical ventilation, because first of all, the humidifier that I spoke of earlier, even though it's very effective in reducing inflammation and providing adequately heated and humidified gas to the lung, it can also kind of act like flypaper. And those larger particles, those small particles are actually going to attach to the aerosol particles, and that particle can fall out of suspension very easily. So keep in mind that during mechanical ventilation, probably the largest factor for reducing the amount of drug that makes it into the lungs is going to be the presence of humidification. Now, am I telling you that you need to turn your humidifier off to give a nebulizer treatment? I wouldn't tell you to do that, would I? But I'll leave that up to you. But you'll see, based on some of the findings from the research that I'm going to show you this afternoon, that really does make a big difference. And that's a major reason why patients that are mechanically ventilated don't get a lot of drug. But also the way that you configure the ventilator, the respiratory rate, the tidal volume, inspiratory time, all those other things can also affect aerosol delivery. But also the size and condition of the endotracheal tube. Remember that ET tube I showed you earlier with a bunch of exudate on the end of it? Well, depending on the condition of the endotracheal tube and how much condensation you have in that breathing tube, that can also act as basically a filter for aerosol in the lung. You also need to consider different things like patient safety. That's a big issue at our hospital right now. Is it feasible to disconnect the patient from the ventilator to give them a nebulizer treatment? Does the risk of disconnecting them outweigh the benefit of actually giving them the treatment? Luckily, most of the kids that we give inhaled bronchodilators to have gas trapping, so we can disconnect them from the ventilator, and they seem to do quite well for a short period of time if we need to bag those drugs in. But the other thing is lung injury. You saw what happened when I disconnected that lung from the oscillator earlier. It completely closed down. So are you willing to run the risk of de-recruitment, Adalecc trauma, by disconnecting them from the ventilator, hooking them back up just for a nebulizer treatment? I'll leave that up to you. The other thing is infection. Every time that you interrupt the circuit, you have the potential to introduce pathogens into that circuit. So many of us wonder if, in fact, there is any improvement in lung mechanics giving these inhaled bronchodilators, and do they work really well in babies? That's the other question that most people ask. And we know that most of the kids that we see in the intensive PICU have some type of respiratory infection. They may have some underlying chronic lung disease, and that they appear to have some response to bronchodilators. And we'll talk a little bit more about that when we do the lung simulation. But one thing that you can look at in your mechanically ventilated children is a flow volume loop. Okay, this is going to be inhalation, and this is going to be exhalation. And you'll see that even as early as 7 days of life and 25 weeks gestational age, there's still going to be some bronchial smooth muscle, and that bronchial smooth muscle may respond well to inhaled bronchodilators. So even premature infants, in some ways, if they have poor lung compliance and they have high airway resistance, they may benefit from bronchodilation. So this here is a child with established bronchopulmonary dysplasia, and this baby's receiving positive pressure ventilation. And if this represents flow rate on this axis and this is tidal volume, you'll see that there's a relatively small tidal volume going into the lung, and then upon exhalation, there's some curvature. All right, there's a little bit of curvature, which indicates that there's going to be, there's going to be two time constants in the lung. One's a slow space, which is going to be the areas that have the highest resistance. Then there's a fast space, which are the areas that have the least amount of resistance. The fast space is going to actually empty quicker, and then the slow space is going to empty later on. That's why you have some scooping of that flow volume loop. And so if we give a bronchodilator, not only do we improve the peak inspiratory flows and the peak expiratory flows, but we also increase the tidal volume for a given pressure because we change the impedance in the lung. And in doing so, we also relax a lot of those small airways that were constricted, and we get more gas flow, and the flow is more linear in relation to the volume. because there's less scooping. We've balanced the time constants in the lung. All right, so bronchodilators are important. It may not be important for everybody, but if you have a kid that's wheezing and they have poor gas exchange and they're on a ventilator, it's worth trying. So how are they administered in the NICU? Everyone has their own separate way of doing things, but when we evaluate some data that was published in 1996 by my good friend and boss, John Salyer, and published in the Respiratory Care Journal, this survey, 85% of the NICUs never even used a pressurized metered-dose inhaler. So do you use inhalers? Are you able to get inhalers for albuterol here in India? Yes? Can I see hands? Like, do you have access to inhalers? Okay, good. Now I know my talk's going to go well tomorrow then. But what I'm really getting at is no one really knows exactly what to do. And in this survey that John Salyer did evaluating bronchodilator delivery practices, 57% of the NICUs will use a PMDI, but only with a spacer. So inhalers are useless if you're not going to use them with a spacer. I'm going to tell you that flat out. 43% of them never used a pressurized metered-dose inhaler with a spacer. And when they did use these forms of bronchodilation, they used them in line with the ventilator only about 31% of the time. 56% of the time they would remove the baby from the mechanical ventilator and they would bag the treatment in, or 13% of the time they do both. So really the practices vary widely between the two groups. Should we disconnect them and give them their treatment? They're not on a humidifier anymore, so maybe they'll get a little more drug. Or do we keep them on the ventilator? That's the question that we all have right now, and I can't exactly answer that for you. But moving forward, if this is one of the only studies, and this study was done in the 80s by Falk et al., and what they evaluated, they took radio-labeled isotopes attached to salbuterol, and they nebulized using a PMDI with spacer, an inhaler with a spacer, and also with a jet nebulizer, a wet nebulizer. They compared what the lung dose was in children with bronchopulmonary dysplasia. And what they found overall, that this is the percent of the drug that was actually being nebulized, and this is what was actually, this is looking at the lung dose, and on this axis it shows micrograms that are being delivered to the lung, or a percentage of the nominal dose that was being provided. And what you find here is only about 1% of that drug is actually making its way down into those BPDers lungs. Right? So 1% of what you put that you're using with that inhaler is making it down to the lung. Whereas with a nebulizer, a smaller fraction of the absolute drug mass is being delivered to the lung than during PMDI with spacer. So this is some really compelling evidence in spontaneously breathing patients unassisted that maybe you get more benefit using a spacer with an inhaler, okay, than a small volume nebulizer. It's certainly quicker, it's cheaper, and 90% of the patients in our hospital are receiving drug that way, rather than having someone stand at the bedside and give a jet nebulizer or a wet nebulizer. So in mechanically ventilated patients, you can observe here that the PMDI with spacer provided more drug than did the jet nebulizer. So this is really some good, compelling evidence in determining, well, hey, should we use a PMDI with spacer or a nebulizer? So the benefits of using a pressurized metered-dose inhaler with a spacer are that you get more efficient drug delivery. You saw those slides evaluating drug mass delivered to the lung. You don't necessarily have to adjust the ventilator if you put a spacer in series with the inspiratory limb, because you're only delivering that drug during inhalation, right? You wait for that baby to take a breath in, give them the breath, right? So you don't have to manipulate the settings at all, because you're not adding a continuous flow to the circuit. You're not messing up the way that they interact with the ventilator if they're flow triggering. So there's potential that you reduce the risk for bacteria and for viruses to be transported into the lungs because you're not using an aerosol from a nebulizer. We discussed earlier that that's a very good vehicle for drugs to get down into the lung. But also, this is much less expensive. And that pressurized metered-dose inhaler can last a long time because it's also a concentrated form of the drug. So, I recently worked with a company to develop a spacer that could be used in spontaneously breathing patients that are unassisted, but could also be used in line with a mechanical ventilator, or can be used with manual resuscitation, with a manual resuscitator. And so this spacer has a pretty unique design in that it's a non-electrostatic chamber. So this chamber, a lot of chambers before it, they're, anytime that you would use an inhaler and discharge the inhaler into the spacer, there's potential for a little electrical charge to occur, and that will reduce your drug delivery right away. That pulls that stuff right out of suspension. And by using a polymer that reduces the electrostatic charge and dissipates that charge, can actually improve your drug delivery by upwards of 50%. So this spacer had to be something small also, because we tend to go into the isolette and give babies drug. So it had to be nice and small and lightweight. Additionally, this spacer, when you push down on the canister, it provides a plume of drug into the spacer so that during inhalation, that drug will go to the patient. Sometimes it takes 3 or 4 breaths before the whole chamber is depleted. Patient doesn't have to be taking a deep breath. Obviously, they can be on a mechanical ventilator, but there's a one-way valve downstream. Okay, so the patient never truly rebreathes medication. There's no potential for backflow to go back into the system, so that every time they breathe out, there's a little air fence that occurs. If this is the system right here, this is the spacer, and this is exhalation. Say the patient is hooked up to this end right here. When they exhale, rather than exhaling those very small particles that didn't deposit into the lung back into the chamber to be re-inspired, the gas flow will take it down into a little passageway so that it can be exhaled out and back into the ventilator circuit. So it's a very unique system, and we never really tested it. And then finally we came up with some funding. And one of the major concerns that neonatologists and pediatricians had is that when we place this in series with a mechanical ventilator, is there potential for CO2 to accumulate, because it could add some dead space to the system. And so we measured, at the time we were doing some rabbit studies, and we measured the CO2 before and after placing this spacer in series during mechanical ventilation. And we found that there was really no significant difference in the carbon dioxide level. So, and also the imposed resistance of these small valves was very low, so we were pretty happy with that. So moving forward, we decided that we'd test the hypothesis that there's no differences in drug delivery between the 3 different modalities that are currently being used in the ICU with regard to pressurized meter dose inhaler and spacers. So what we wanted to do is provide manual ventilation via an endotracheal tube. We wanted to provide mechanical ventilation with humidity via an endotracheal tube, and then also evaluate spontaneous breathing with a face mask. No one's really ever done this, especially using a realistic lung model and evaluated the full range of patients that we take care of in the pediatric world. This includes everything from a premature infant all the way up to a large or small child, toddler. So the best we could, we simulated lung mechanics, and I was able to go through and find many different references to put the proper resistance and compliance, tidal volume, respiratory rate, all of those things to mimic a premature baby, a term neonate, and a toddler. And what we did with these 3 patient groups with the lung model is we attached some filters at the lung model, and then hooked this up to the ventilator. And this is the flow sensor. Keep in mind, folks, that if you're going to give, this is a little aside for a moment, but if you're going to give inhaled bronchodilators or any drug for that matter, make sure you take your flow sensor out, or you put the treatment more proximal to the patient and distal from the proximal flow sensor. But I would suggest taking that flow sensor out, because you're going to get a bunch of that medication into your flow sensor, and it's not going to work very well. So we provided mechanical ventilation using a properly sized endotracheal tube to the test lung model, and we gave 4 puffs of albuterol, and we evaluated it with the preemie, the newborn, and the small child. And then we put a resuscitation bag in a plethysmograph using a different ventilator, and we mimicked hand bagging as close as we could with each of the patient sizes using this new spacer and this new inhaler. And then we used a very realistic face model hooked up to the test lung And for the neonatal, we used a smaller infant face mask or upper airway model, and then a larger small child for the small child model, and we evaluated medication delivery during spontaneous breathing. Results. So what we found, there were consistent findings across all the age groups for the lung model that we used. What we found is that during mechanical ventilation, the absolute drug mass that was provided to the filter during mechanical ventilation was around 3.3, 3.8, and 4.2. There was a twofold greater and sometimes clearly a threefold greater increase when you manually resuscitated the lung model for the different patient sizes. I wonder why that is. Does anyone want to tell me why? There was greater drug delivery at the same volume, same rate with a manual resuscitator compared to a conventional ventilator. Does anyone want to try to guess? Humidity. The humidity reduces aerosol delivery. So you get 50% more when you remove them from a ventilator and you bag it. All right? I'm not telling you to remove your patients from the ventilator, but you know, I'm not saying that I never have either. But in spontaneous breathing, clearly the amount of drug that was delivered to the filter in the lung model was similar to during manual resuscitation because we don't have a humidifier. So humidity is kind of not so much your friend but your foe when you're delivering inhaled bronchodilators. Now I'd like to try to focus on different drugs, and I kind of talked about pressurized meter dose inhaler with a spacer. In my laboratory right now, we are really intensely focused on trying to understand a little bit better how different types of wet nebulizers deliver drug using different positions. All right, so for years, we always thought that we would put the nebulizer back at the humidifier in the inspiratory limb, or maybe we'd put it at the proximal airway. Maybe we wouldn't use it at all. And so everyone had their own way of going about it. And it may be different for adults, but in neonates and small pediatric patients, we recently completed a test where we just wanted to test the hypothesis that there were differences in drug delivery between conventional mechanical ventilation and high-frequency oscillatory ventilation. This is pretty important. And the reason why we wanted to do this is because we received a grant with one of the cardiologists to study iloprost. And inhaled iloprost is a pulmonary vasodilator. And what we were finding is that the majority of the babies or children that we were trying to enroll into this study, they weren't on conventional ventilation. And we only believed that the only way that you can provide this drug was during conventional ventilation or in a spontaneously breathing baby. Most of the babies that we tried to enroll into the study were receiving high-frequency oscillatory ventilation. So we said to ourselves, well, you can't give inhaled drugs with an oscillator. I mean, we still don't understand the complicated fluid dynamics of how a high-frequency oscillatory ventilator operates. You know, there's a tremendous amount of resistance, short inspiratory times. There's no way that you're going to get any drug into the system, so we didn't enroll anyone. We never enrolled anyone into that study with Delphine. And so I took it to the lab and I said, well, you know, there might be a possibility that you could get some drug delivered to the lung when you're using high-frequency ventilation. But so we had basically 4 testing conditions. We wanted to evaluate drug delivery proximally, as close to the endotracheal tube as possible in the inspiratory limb, and back at the ventilator. So remember that this is proximal, this is distal during conventional ventilation. This is going to change your practice a little bit, I think, because no one's done it before. Not because my research is good, but because no one's done it before. Okay. So here's high-frequency oscillatory ventilation. Remember I mentioned that we wanted to test the hypothesis that there's differences? Well, you got to test that nebulizer in every available location that someone can come in there and place it. So we place the nebulizer close to the patient and then back here at the humidifier. Who's ready for some results? You ready for some data? Okay. So what we found overall, when you place that nebulizer as close as possible to the endotracheal tube, you get more drug. That's not a big surprise during conventional mechanical ventilation. In larger pediatric patients, there comes a point where you're using slower respiratory rates, and that relationship changes, where you may want to put your nebulizer back at the humidifier because the circuit becomes a reservoir where the nebulizer will push gas or push aerosolized bronchodilator into the circuit, or iloprost into the circuit, and with larger filling times, you now fill that circuit, and that creates a bolus and drives the drug back into the lung. But with neonates and small pediatrics, place that nebulizer proximal to the endotracheal tube, and you'll get a 5-fold greater drug delivery. Additionally, it's always nice to get unexpected findings in research. Never once did I realize that there would be a nearly 30-fold increase, or I should probably say 3-fold increase in drug delivery using high-frequency oscillatory ventilation compared with conventional ventilation. You can give drug with high-frequency oscillatory ventilation, and I don't know what the exact mechanism is, but when you place it right there at the endotracheal tube, compared with placing it back at the distal portion right by the humidifier, yeah, there's a 30-fold increase in drug. So who would have ever guessed, you know? And I think that has to do with the fact that we're using a much greater frequency. We're using a much higher frequency than we would during conventional ventilation. There's some suggestion that maybe during the active exhalation of high-frequency ventilation, you're dragging some of that nebulizer back into the circuit, some of that nebulized material back into the circuit, so that you get a big bolus with the next breath. I don't know why. I'm still trying to figure this all out. And a couple of my engineering friends who are into fluid dynamics, they're perplexed by our findings. But other people are studying this now too, and finding out that you get more medication delivery during high-frequency ventilation than you do during conventional ventilation. So that's a good take-home message. So the other question, and keep in mind that the nebulizers that we use for every one of our patients that are mechanically ventilated now, it's not going to be a wet small volume nebulizer that's adding flow to the system. We're going to use a vibrating mesh nebulizer that adds no flow to the system, has really good particle size. If you have a little bit of additional money, they're nice to purchase. But if you don't, then settle with your standard nebulizer. And if you don't prefer to use that because the patient doesn't look good because they can't trigger the ventilator, take them off, bag your inhalers in. You're going to get 50% more. But if they really need that drug, it's okay to bag it in there. All right? What about non-invasive ventilation? Have you ever wondered, I want to do mask ventilation with this child and hopefully try to avoid the need for invasive mechanical ventilation? Some of you may have BiPAP, or you use your current mechanical ventilators to, most of the ventilators nowadays have a non-invasive mode. The Servo-I ventilator, the Avia ventilator, all those ventilators you can set up, and rather than using an endotracheal tube, you can place a face mask, and there seems to be a lot of interest in doing that nowadays, especially in your asthmatics. We don't have many asthmatics that are intubated any longer. But I've always wondered, well, where should we be putting the nebulizer with this system? And this is a complicated system because it uses a single circuit. And the way that a patient exhales through this circuit is you have a little window, a little leak, a little integrated leak valve that eliminates CO2. So, well, do we put that before the leak or after the leak? Should we put it by the humidifier? And so it's difficult to put your nebulizer after the leak because there's no mask that's commercially available that allows you to do that. However, until recently, there is a mask that's available. I apologize for the quality of the graphic, but there's a mask that allows you to integrate a small nebulizer right at the nasal airway. So we wanted to actually test this device, and what we found, this is going to be pre-humidifier, pre-leak, pre-mask, pre-leak, and this is going to be intra-mask, post-leak. It's no real big shocker that when you put that after the leak and as close to the patient as possible, you get more drug deposition. If you don't have the ability to use this nebulizer, then it's important that you place that nebulizer as close to the patient as you can. So that's your take-home message. In non-invasive mechanical ventilation, place it as close to the patient as you can, using whatever nebulizer you have. Okay? So my last few slides here are going to discuss something that is kind of near and dear to me. It's nebulized surfactant. Many of you in the room have instilled lung surfactant through an endotracheal tube. In order to do this, you need to keep them intubated for a short period of time, a couple hours, maybe a day, and you have to manage them on a mechanical ventilator. Well, the question comes along, well, I want to use nasal CPAP, but I do know that my patient could benefit from surfactant, but I don't want to intubate them because that causes lung injury, right? So people are trying different tricks. Some people are letting the patient breathe on CPAP and taking a laryngoscope and a thin catheter and placing it just past the glottis and injecting surfactant into the lung and allow them to breathe it into their lung and as tolerated. That seems to be working quite well, and you never have to intubate or mechanically ventilate your patients at all. Other people are suggesting that we can aerosolize the stuff, and now that the nebulizers are way more efficient than they used to be, there's some utility in doing that. And so one of the most recent publications, this was published at the Pediatric Academic Society meeting, Marla Wolfson, Tom Schaefer, and all the group from Temple University. They used their preterm lamb model, and their preterm lamb model is 104 days of gestation. That's roughly equivalent to a 20-week premature infant. So if you look at the lung structure and architecture, it mimics closely the lungs of a 20-weeker. And these animals are around 1 kilo. And what they did is they supported a group of these lambs with just CPAP, and then they supported another group of lambs with CPAP and aerosolized surfactant. So they took the surfactant and they aerosolized it, had them breathe in, and I believe they gave up to 2 doses, and they supported them for a number of days. And what they evaluated in time at baseline and at 4 hours, in the group that was supported with just CPAP, you can see that their oxygenation did improve a little bit, but it wasn't significant. Well, yeah, they're on CPAP, and then you look at the group that was treated with CPAP and AeroSurf, the PO2 didn't really change that much. And same with the CO2. From the baseline measurement to 4 hours, there wasn't much change. It's tough, though, with gas exchange in a spontaneously breathing lung model to expect that there's going to be any differences. Compliance, there was an improvement in compliance in time with these animals, with both groups, and they weren't different. And the functional residual capacity, there was no difference between baseline and the 4-hour period. The same holds true for compliance and also pH and breathing frequency. But where it becomes very interesting is when these animals were sacrificed and they evaluated the pro-inflammatory response in the lung, there was a significant improvement, and there was lesser inflammatory mediators in the lung in the group that received CPAP with aerosolized surfactant. So overall, there's less lung injury. And when you look at histology in the group that was treated with just CPAP alone, you can see that the air spaces tend to be more collapsed. Maybe there's some thickening of the highlight or the pulmonary capillary membrane, and also, or the interstitial space rather. If you look at the group that was supported with CPAP and surfactant, there seems to be more uniform lung inflation throughout. The air spaces are larger. So overall, there was less injury and there was more inflation in the lung when these animals were treated with aerosolized surfactant. We're not really sure where we're going to go next with all of this, but we are planning in my lab to study a form of surfactant that costs about 30 cents a dose. We've worked with the Bill and Melinda Gates Foundation to try to make this a form of surfactant that in time we may be able to make available to people in resource-limited settings at 30 or 40 cents a dose instead of $1,000 or $1,200 a dose. And it's basically ExoSurf. You've probably heard of that. It's a synthetic form of lung surfactant. And so we're going to evaluate in spontaneously breathing animals receiving CPAP drug delivery using this drug, but also using one of those Aerogen nebulizers that don't add any additional flow to the system. So I guess that's going to be the end of my discussion. I've gone over my time a little bit, so I probably don't have a lot of time for questions, but maybe I could take 1 or 2, that would be all right. Thank you.
Thank you, Dr. de Blasi. Now, may I invite now our next speaker, Dr. Zimmerman, to have his talk on difficult weaning tricks and trade. Dr. Zimmerman, please.
Try to stay awake after that good lunch. We've got the patient now intubated on the ventilator, and now we have to think about getting this patient off the ventilator. And what I'm going to discuss in the next few minutes here are some tricks for getting patients off the ventilator, or at least weaning them when it is particularly difficult. Doesn't advance. Okay. So in thinking about this, there's two major things that you might consider. One is issues related to respiratory load, and these are things that are related to the lung disease itself, things external to the lungs, particularly the heart and how it's working, the chest wall, and usually this relates to how much chest wall edema is present. And then the other side of the equation is the capacity of the respiratory system or the pulmonary system, and this involves the muscles of breathing, whether or not there is respiratory drive present, and the function of the neuromuscular system. So what I'm going to talk about, and there are many things that we could discuss related to tricks of weaning, are the subjects here. The fact that there may be ongoing acute lung injury and you just have to relax and sit tight for a while longer. Here's fluid overload again, excessive sedation, deconditioning of muscle, including the diaphragm, ventilator-associated pneumonia. You heard a lot about this, a lot of detail from Dr. Krotkin this morning, and I'll just discuss this briefly again. Systemic disease, especially cardiac disease, dysynchrony with the ventilator, and then lastly, the concept of chronic lung disease, old and following this acute lung injury that may necessitate long-term mechanical ventilation. So first of all, it may not be time for weaning to proceed with this patient. So this patient may be continuing with the acute lung injury, and now there are a number of ways to evaluate this quantitatively, and there's several references that I've provided for you. But the idea of looking at the ratio of inspired gas, of the PO2 to inspired gas, or the saturation divided by the fraction of inspired gas, the dead space fraction, and the degree of pulmonary compliance, all of these may give you clues that the lung injury that's still present is too much to expect any significant weaning. But that being said, you should have a standard work in your unit to daily undertake an extubation readiness test. And this may mean that the patient has to be on less than 50% oxygen, and the PEEP has to be less than whatever number, 8 or 5, something like that. But for the patients where this is appropriate, try them off the ventilator. Try them on a spontaneous breathing trial, because you will be surprised. Some of these patients will be ready to extubate even when you didn't expect it. Fluid overload. I talked in some detail about this morning. The reason that I continue to harp on this is because it is so common, and we need to pay more attention to this, and I'll show you some evidence that this is in fact important. So the fluid overload not only relates to pulmonary edema in the lung, but the chest wall may be edematous and greatly impair the ability of the patient to take an adequate tidal volume. And then airway secretions may be copious and impair gas flow. So for all of these reasons, it is important that the patient is not fluid overloaded. So there's some good evidence, first of all, from the ARDS network studies, that a strategy that involves a conservative fluid management approach results in better weaning, fewer days on the ventilator. And then just recently, last year, Another study related specifically to pediatric acute lung injury was published, and the results were that there was an independent association between ongoing positive fluid balance and ventilator days. So here is some, I think, very interesting information about all of this. So what you're going to see here are some data from the ARDS network study, one of them, and then looking at the same type of data in pediatric patients with acute lung injury. So first here is days on mechanical ventilation, and on the y-axis, the daily fluid balance in terms of milliliters per kilogram. And the first graph, the first bar, is the adult patients on the FACT conservative fluid strategy, those on the liberal fluid strategy, and then a similar cohort of pediatric patients, the way that we as pediatric intensivists would care for these patients. So what you see here is on days on mechanical ventilation, we are providing way more fluid to our patients than was seen even in the liberal fluid strategy adult patients. So we are giving our patients, at least based on adult data, too much fluid. Another way of looking at this is fluid accumulation over the days on mechanical ventilation. So there's three lines here. The first is the conservative adult group in that study. And as you can see, as days on the mechanical ventilator progressed, there was actually ultimately a even fluid balance. Here is the adult group liberal fluid strategy and with a daily accumulation of fluid. But here are the pediatric patients with acute lung injury over a similar period of time, significantly more fluid accumulation over that first week of mechanical ventilation. So it is not surprising, at least to me, that we might have trouble weaning our patients from the ventilator because they are fluid overloaded. So moving away from fluid, I will stop talking about that now and switch to sedation. When Adrienne Randolph did her trial examining different modes of weaning from mechanical ventilation, she really didn't find any differences in terms of the correct strategy to utilize. But one of the conclusions of that study was that perhaps a third of the patients were slow to wean from the ventilator because they were excessively sedated. They didn't have a proper drive to breathe. So in terms of sedation in the intensive care unit, there is no question that these drugs provide safe application of the ventilator. They make our patients comfortable, and they promote synchrony with the mechanical ventilation device. But at the same time, these drugs inhibit cough, they decrease the respiratory drive, and by decreasing muscle activity, they lead to lean body muscle catabolism and deconditioning. So there are two studies that have been published. First is another study, the same study by Dr. Randolph that I noted earlier, that excessive sedation impairs weaning from the ventilator. And then a second study that was conducted at our hospital in Seattle, where we demonstrated that implementation of a sedation protocol where we empowered the nurses to wean sedation when a target comfort score was reached, resulted in significantly fewer ventilator days. So we do a good job at resuscitation and turning things up, and I think we need to pay more attention, especially with sedation, to weaning it from the patient when it is appropriate, because it will reduce the time on the ventilator. Now, speaking of deconditioning, let me give you an example. When you are sick with your influenza and you are lying at home in bed wishing your mother was there to bring you some soup, and you feel like you are dissolving from the inside out, you are. And this is part of the acute stress response. You mobilize amino acids from your lean body muscle, especially alanine and glutamine, and these amino acids are utilized to synthesize acute phase reactions. They're utilized for gluconeogenesis, and they are utilized to expand the immune system. But if this is excessive, you can imagine that there will be muscle weakness, including the diaphragm, and this is termed deconditioning. And even a short run on mechanical ventilation can result in protein loss from the diaphragm and less effective breathing. So here is just some physiology and chemistry behind this. These are patients who were mechanically ventilated, and these are patients, control patients without mechanical ventilation. And this study actually did serial biopsies of the diaphragm. And you can see among patients who were receiving mechanical ventilation, there is a decrease in the fiber size, the concentration of the slow myosin fibers and the fast myosin fibers, and graphically this is shown here. The two different types of muscle fibers, both decreased in patients receiving mechanical ventilation. This is another way of looking at the same thing. This is gel electrophoresis of diaphragm proteins, and these proteins extracted from the muscle are stained to see which are conjugated to this chemical called ubiquitin. When ubiquitin is attached to protein, it is a signal for protein breakdown. So shown here are different proteins of different molecular weights. Here are the mechanically ventilated, the control patients compared to the mechanical ventilation patients, and you can see all these proteins that are signaled for breakdown, for catabolism. This is the biochemical basis for deconditioning. And shown graphically here are the control patients with these proteins destined for breakdown as compared to patients on mechanical ventilation. So in adult medicine, this scenario is very well studied and correlated with a number of events, including the lack of mobilization, use of corticosteroids, etc., lots of sedation. We have much less information in children, but probably should think about deconditioning as a cause of failure to wean and extubate. Dr. Kratkin talked extensively this morning about ventilator-associated pneumonia, but certainly one of the things that needs to be thought about when a patient is recalcitrant to weaning is that they may have developed a ventilator-associated pneumonia. So if the pressures required to achieve a tidal volume are going up, the compliance is worsening. If the chest x-ray is looking worse, if secretions are now colored and excessive, this patient may have a ventilator-associated pneumonia, and you may have to step back, treat that pneumonia before you will be successful in terms of weaning. So there's a number of things that are associated with ventilator-associated pneumonia, sedative drugs, a gastric tube. One of the things that we can control is days on the ventilator. As we talked about just before lunch, if possible, if your patient is not too sick, if you use non-invasive ventilation instead of a ventilation through an endotracheal tube, you will certainly decrease your risk of ventilator-associated pneumonia. So this entity kills patients. It's very expensive. In the United States, about $30,000 on average additional cost for patients who have a case of ventilator-associated pneumonia. There are strategies to decrease this problem. As Dr. Kratkin said several times, diagnosis is a challenge, and there's a lot of people looking at this right now in adults, children, and neonates. It's important that this is recognized early and treated early because if not, it will certainly impair weaning from the ventilator. Now, another thing is it may not be the lungs that are the problem at all, but some systemic disease. And this is especially important for patients with cardiac disease. In adult medicine, it's coronary artery disease. In pediatrics, it's children with congenital heart disease. So when we are weaning a ventilator on a patient with cardiac disease, this is really a stress test, a cardiac stress test. Because when you think about it, before application of mechanical ventilation with normal spontaneous breathing, there is improved right ventricular preload, and there is increased left ventricular afterload. When we apply mechanical ventilation, we reduce right ventricular preload and we reduced left ventricular afterload. At the time of endotracheal intubation, bang, we change everything back to the way it was with spontaneous breathing. So increased preload, increased afterload. If you have a sick heart, this is exactly what you don't want, and this may be an important reason why the patient will fail weaning. So there is interesting literature on this subject in adults utilizing a biomarker, B-type natriuretic peptide, actually it is fairly predictive. I can't read the numbers, but if your B-type natriuretic peptide increases during weaning from mechanical ventilation, this patient is likely to be in big trouble if you proceed with extubation. So here is a summary of this type of thinking. This is on the y-axis change in B-type natriuretic peptide as a percent. Here are the three types of patients: failure of the spontaneous breathing trial, failure of the extubation attempt, and success of the extubation attempt. And what you can see here is the patients who, with cardiac disease, typically who are successful in their extubation, their B-type natriuretic peptide, a measure of myocardial stress basically, stays the same or even goes down. But for those patients where this biomarker increases, these patients typically do not do well when they are taken off of mechanical ventilation. Another application for non-invasive positive pressure ventilation potentially for this type of patient. Lastly, patients may be dysynchronous with the ventilator when you are trying to wean it down, so adjusting flow, adjusting the amount of positive pressure support with your respiratory colleagues may be very valuable when you see this sort of pattern. So Dr. Foley is going to discuss in detail neural-assisted ventilation and actually linking the breathing effort to the action of what is going on with the diaphragm. So I am not going to talk about this except to say that this is one way of achieving synchrony with the ventilator. Not many of us are using it, but in at least a few studies in neonate, it has been shown to not change vital signs and perhaps decrease the amount of support that is needed. I'll let Chris really give you the details on that. Lastly, we take care of patients in our units that have chronic lung disease, and their lung process, their lung disease in the intensive care unit may result in chronic lung disease. So this is a picture of what I would call a prototypical baby with bronchopulmonary aplasia. Here is the X-ray, small cystic disease, hyperexpansion, so both restrictive and obstructive chronic lung disease. Here is this, I would call anxious appearance, steroid facies. This poor kid is in a mess, and things are not going to get better for this child. So at some point, we actually may need to make the decision that, no, we're not going to be able to wean this ventilator, and we're not going to be able to extubate this patient. In order for this patient to grow and develop appropriately, he is going to need mechanical ventilation for the long term, and probably will need a tracheostomy airway to facilitate that.
And so what we do is we get plateau pressure, say, of 25 or so. You set that peak pressure on APRV, the high pressure, at being roughly 3 to 5 above that. So let's say 28 to 30 to set your high peak pressure. And so you will stay at that pressure for a long inspiratory time. So the worse the oxygenation they have, the longer you drag that out. So you're really thinking about releasing and letting them breathe only so often. And that's how this works. Airway pressure release is that you maintain a high peak. They breathe across that spontaneously. So they're getting some CO2 clearance with that. They do have a little bit of extra stretch when they do that. But then you release it so they actually, remember exhalation is the passive mode for most of our patients. You release it so they can exhale for a matter of a half to 1 second. You don't ever get all the way back to baseline, otherwise you're losing all the improvement that you just had and all the peak that you acquired. So you drop it down, and we'll talk about how much to do that, but you drop about 50% of the flow comes out in that half a second to 1 second, and then you go right back up to that high plateau again, and then you breathe across that. And you might release them every 4 seconds, every 3 seconds. It sort of depends on what the patient's able to do and how well the ventilation is going and things like that. So they're breathing across the high peak, they drop, they come back up. And I have a graphic, Rob was writing it down, but I'll show you what the graphic looks like. So when they're spontaneously breathing, that's these oscillations here. They release, they exhale during that time. They can breathe at any time during this, so they can still breathe on the way down, but again, it's only a half second to a second, so there's not a lot of time there. And then they go right back up, and they're breathing across that. Okay? And that's really what we're trying to accomplish is high mean airway pressure. Remember, that's what our oxygenation is all about. But letting them spontaneously breathe, and that's better CO2 clearance. So what we do when we set up the ventilators, we go ahead, you can walk me through it. Take your
Basically, we have two CPAP settings we have to do. P high, one CPAP, and we have low CPAP, that is your P. So we set a high P at 15 and low P at, that is your P at 5. And then we set a tank, stand cycle, pressure. So we set a tank that is I ratio is 7:1 right? So we set PI for 3.5 seconds.
I time is more than
I time is more than the expiratory.
Yeah, this is definitely
The lower
inverse.
inverse ventilation.
Inverse ratio.
It's on purpose. Yeah.
But in inverse ratio ventilation, you have to sedate and paralyze the patient. But in APRV mode, you don't have to sedate and paralyze. Patient can breathe on both the CPAP level. So we have the time for T high 3.5 seconds and time for low CPAP, that is P is 0.5 seconds. Then we set the inspiratory cycle. When the patient is breathing spontaneously, the flow drops to a certain percentage. The machine cuts off the inspiration and it will allow the patient to exhale it out. So we have an inspiratory cycle and we can support the patient at both the CPAP levels, as well as the P high as well as lower CPAP. We have added a threshold cycle. When the patient is not breathing, is not taking active inspiration, machine will act as a control ventilation.
This is just inverse ratio ventilation when you're not spontaneously breathing.
And we have not set any respiration rate in this. Depending on your T high and lower CPAP time what we are giving, that will be your respiration rate. So So I have said 3.5 and 0.5. So the total cycles become 4 seconds. So your respiration rate becomes 15 breaths per minute. Okay. And whenever the patient wants to breathe a breath, it will be on a P high or it will be on a P low. Patient can breathe with the pressure supersonic. This P high, and then patient can breathe on both the CPAP. So the mean airway pressure doesn't drop. The alveolus doesn't re-recruit. There's continuously recruitment is happening in the patient lungs. With the mean airway pressure on a high side. It's on P high for 0.5 second it drops. It will wash out the CO2 in the patient's lungs and then it will again rise. So in ARDS cases, you don't want the alveolus to collapse. You can use this mode in those patients where you have a ventilation to the patient.
So when we look at this, here we have breathing spontaneously, we release, and we go breathe back to breathing spontaneously. When we look at this waveform, this has to do with inhalation, exhalation, and flow. And this is what we want to look at. Can you go ahead and breathe that? Okay. So what we're looking at on this bottom screen specifically is on exhalation, we're exhaling. This is inhalation. We go up to the high peak, and then we breathe spontaneously. That's the flow. And then the flow, when we drop down for exhalation, comes back only about 50% to baseline, so we're shooting for. If it comes all the way back to baseline, you run the risk of losing recruitment because you go back to a peak of 0. So we're intentionally trying to create auto peak that's going to maintain alveolus integrity. But we want this to be about 50%. So if we're 100 liters a minute, as a big patient might be breathing, we want 50 liters per minute flow to be roughly what we're exhaling and then getting back to the high peak. So you look at that waveform here. Okay. The flow is 112. What do we want that to be on exhalation? Roughly 60, 56 or so. Right. And so if it's low, what we want to do is increase the time when we get to the exhale. Let them exhale a little bit longer so they get a little bit more flow out. If it's high, then we might have to shorten that, or we might have to give them a bigger flow breath. So that's how we interpret this on exhalation to make sure that they're not exhaling too much down to baseline and they're not exhaling enough to clear CO2. People understand that concept? So you have to look at the graphics. That's why this ventilator, you really can't do this mode without this kind of ventilator, this kind of setting with the graphics package. Without it, you really are flying blindly. You don't really know what you're giving. And when people talk about bi-vent support, bi-level support, APRV, they're all synonyms. It just depends on how you set it up. Bi-level tends to be a little bit longer time exhale, and it's more of a recruitment type thing. It's not really a support mode the way this is. This is more like what you're going to do for somebody who's headed toward the oscillator. Who's going to need a lot more support and needs high mean airway pressure, and you really only want to release it for a short period of time. And bi-vent is similar to that. And you can do those modes on those ventilators. You just have to shorten the expiratory time. Okay. BiPAP?
High level CPAP.
So that is non-invasive.
Yeah.
This is invasive.
Right, no, this is on the ventilator. Yeah, and on BiPAP to maintain that peak, I would challenge you.
Sir, if you are using a pressure control ventilation with a inverse ratio ventilation, the patient triggers, it again goes back to the baseline and it starts a ventilation. So there's a de-recruitment is happening. But in the high vent, the patient breathes, he can breathe on both the CPAP levels. So it doesn't go to the same the ventilator having this mode, it can be the specified mode. Same thing you can do it in pressure control ventilation with the inverse ratio. But in that the patient triggers, if you go to the baseline, it will start a new breath. We don't want that. We don't want that de-recruitment to happen. In this, the patient breathes, patient can breathe on both the CPAP levels. So all the lungs are always
Probably not necessarily no, because you're not getting as much
no,
strength.
patient can breathe
More like the
spontaneously.
oscillator, and then you maintain the airway pressure, but you're not having that large delta.
The setting,
But just temporarily. So you're really
depending on the
not
opening pressure and the closing pressure. So the height,
oscillating across
pressure, P height, and the low pressure.
It's just
That depends on the patient, sir. At what pressure the alveoli are collapsing, and at what pressure the alveoli are opening.
breathing. You have to think that they're doing a little bit more opening and closing on their own. So it doesn't all.
This time, sir.
Yeah.
Machine will give those time
have to be
cycles. The
innovative
patient
in
can
this.
breathe on both
This
the
particular
CPAP
mode,
level.
BiPAP, is very challenging.
It's always there. It's always there. It's always there.
So all the breaths are patient initiated breaths, or when it is
Now,
initiating
patient
any
can
breath,
initiate a breath, but machine will support on both the CPAP
the
level.
machine is supporting the pressure with the pressure, but the machine is not initiating like SIV or IMG. It is not.
Yeah,
It is only the pressure that is
The cycling
maintained,
is there.
and the patient will have his spontaneous own breaths.
Own breath. Biobank. We call this biobank in this machine. Another machine is the APR.
Right. It depends on what
The
machine you're on.
latency
bi-level,
is, we don't have that
APR.
latency. They have taken that latency from, so we cannot name the same.
Right.
That is the thing.
But they're really the same modes. They just call them different things.
Working-wise,
You have to set them up a little differently sometimes as well. But the principle's the same. The heat issues. Oh, heat-ID ratios, they're out the roof. We don't care. I mean, we're intentionally giving them an inverse ratio, and we're not really worrying about it. You do have to adjust accordingly. If their ventilation is poor, then you either have to give them more release time, more times releasing, shorten your eye time, and then you're going to sacrifice some oxygenation for that. So it depends on what balance you need to strike. But in general, this is the mode that we're really using to maintain mean air pressure more than we want worrying about ventilation. Weaning from this mode. So the way we typically wean from this mode is to drop our P high and lengthen out our eye times. So we're having fewer cycles and fewer releases, but they're breathing more spontaneously across a more normal peak. And then as the peak comes down to maybe a 10 or a 12 range, you can actually extubate them to BiPAP from there if they're breathing spontaneously. So you wouldn't necessarily convert it back to mechanical ventilation. You just maintain the peak but drop that steadily. So if they started a P high of maybe 25 or 30, you're going to steadily go down probably in increments of 4 to 6, down to 14, 15, and then maybe down to 10. And then probably you'll extubate them from that if they're waking up and they're ventilating. Remember, our reason for extubating patients so slowly is usually because we have to let them wake up. We've sedated them and paralyzed them for a long time. And this really changes how we approach the really sick patient who needs high ventilation, but to let them breathe spontaneously. It seems a little opposite to us, but it is something that the more experience we're getting with this, the better it's working. And we're never having to go to the oscillator for a lot of patients. We're able to do this instead. High mean airway pressures, but in a different mode. What's the maximum?
So we are limiting the pressure.
I think once you get up to 35, everyone gets a little anxious.
APR is high.
You're worried that you're going to breathe too much out of it, and you're going to have your spine lung segments over.
But machine will able to maintain that
It's really not a
pressure.
PI, it's P high.
Try to maintain the pressure.
But they're too peak.
So we are in pressure. So we can limit the pressure. We can always limit the pressure.
Yeah, I mean, when they spontaneously breathe, it's really going to be just oscillation across that. It's not going to get really high. And somebody asked here, and I think it's worthwhile for everybody, is there a limit to how high we would set the P high? And most people would say between 30 and 35 would probably be as high as we would go, wearing that our confined lung segments are getting overdistended, and that you're probably running the risk of hurting them. And so those patients are then either going to be converted to the oscillator, and that just maintains your mean air pressure maybe a little bit better than this will. Or you're going to have to just work with lower pressures and accept that you're not going to have quite that distension that you want. That really depends more on airway resistance and obese patients and something like that. I think people who have large abdominal contents or really thick chest walls, obese patients, you might get away with maybe even as high as 30 or 40, but I think it would be a unique circumstance.
In case of CPAP pressure, we can directly use this instead of mechanical ventilation.
Do you mean just with a mask?
In case of
Instead
CPAP
of
failure, we
conventional.
can directly use this. For any case, even if
Oh, I see
we
what
add
you're saying.
in
You could.
other ventilation also.
Yeah, you absolutely could. You just probably wouldn't set it
Better
as
than
high.
in mechanical ventilation, it's working better.
It might. Yeah, it really depends on your lung process. If what you need to do is recruit, this is a good tool to do that.
You have to keep the lung open.
No, only in air other cases.
Well, the nice thing about this is it's spontaneously breathe, where if the oscillator
You can do spontaneous
is breathing, and they'll keep setting off the high pressure number. So most of the time our patients actually paralyzed the state of the oscillator. Whereas here, there are some people even get to the point where the patients are falling asleep, or interacting and playing games, but still on this mode. So that's really the advantage. Okay. NAVA. We want to talk about neurally adjusted ventilator assist, NAVA. And that's really sort of, it's a new mode. It is not being used across the country by any means in the United States. It's mostly being studied. But when we think about how we let people spontaneously breathe, it's flow triggered up at the endotracheal tube. Actually back to the machine in most machines. So this is one mode that allows us to try and trigger based on the diaphragm activity. So it uses a catheter that has multiple sensors that basically are at the bottom of the esophagus where the diaphragm is going up and down. And when we place that, we'll get deflection to know we're in the right place, and then it follows diaphragm activity and it interprets that diaphragm activity to sense a breath. So when the diaphragm triggers it, you get a breath that started from a diaphragm movement, not from flow changing in the airway, which, as you well know, is hard to sync with a fast-breathing patient or a patient who has a lot of airway resistance because they're breathing back and forth, and by the time the ventilator catches up to what they trigger, they're actually exhaling already. So this is the mode that's going to be more comfortable. Dr. Zimmerman showed in this slide, and I have some slides I can show you as well, that patients who are trying to synchronize with standard mechanical ventilation, when all we use is pressure support, they're often stacking breaths or they're having to abort a breath halfway through. It's not very synchronized at all. But with this neurally adjusted ventilator assist, they are actually able to breathe as much as they want, and we give them a breath every time they trigger it, and we stop it when they stop. So you get these short breaths, but it's much more comfortable. So it's really like pressure support, but it's not on a flow trigger, it's on a diaphragm trigger. Yeah. And that's another one, you have to have the right machine. You can't just do it with everybody.
Normally ventilator works when the patient triggers the breath, the negative pressure is created, then the machine senses it, and then the machine delivers the breath. So there's a time delay, it's more than 100 milliseconds. When the patient has taken a breath, the time delay is more than 100 milliseconds. So there can be patient maybe fighting with the machine. If the patient wants to exhale, the machine is delivering a breath. So what this now does is, we take the electrical activity which is coming from the phrenic nerve to the diaphragm, where the excitement is happening. These activities are taken by these catheters. They pick up by this catheter, and the signals are given to the machine, the ventilator. And the machine delivers the breath according to the patient's need. It is 100% synchronized with the patient's requirement. Okay? And this, the pressure support is also according to the patient's need. We don't have to set a pressure support. We just set the NAVA level. Depending on the EDI peak and EDI minimum, the pressure is adjusted. If there are strong signals coming from the patient will get a good tidal volume depending on the EDI high and EDI minimum. So whatever NAVA level we set, that is multiplied by EDI high minus EDI minimum, multiplied by at plus P. That will be a pressure support. So the pressure support will keep on changing according to the NAVA EDI signal which
how
are
much the
coming.
diaphragm pulls. So it adjusts based on how deep a breath they're taking. They're taking real shallow breaths, do relatively small breaths. They take a big sigh, they get a bigger breath.
So this is normally the machine will give a breath. When the patient triggers a negative pressure is created, then machine will give a breath. But in this, if the diaphragmatic activity is there, the excitement of the diaphragm, the machine gives a breath. As soon as it gets the signal from the phrenic nerve. So this is where the machine gives a breath, rather than wasting 100 milliseconds and then giving a breath. So we put a catheter at the diaphragmatic level. The same catheter is used as a feeding tube also. So we have sizes starts from 6 to 16 French. So right now we have 8 French catheter with the size in it. So there are electrodes over here which catches the electrical activity of the phrenic nerve, electrical activity of the diaphragm. And these signals are given to the ventilator, and the ventilation is given to the patient according to the patient need. Rather than we deciding the pressure support, patient decide what pressure support he wants and when he wants it. So this is the NAVA catheter. For this we require a software as well as hardware and this connecting cable and the EDI catheter. These are the catheters what we have. We have different installation all over India. The biggest is the AIIMS in India, Delhi. They are continuously using this catheter.
It's still relatively experimental and it's super expensive.
This is the lumen. It can be used as a feeding tube also. So you don't require an additional tube. So we depending on the patient, we decide what size catheter he requires. It starts from 6 to 16 French. So this is a sterile pack, and then we get this cylindrical activity is refined, and then it is given to the ventilator. So we have this NAVA signal which is coming. It is synchronized with the patient. The machine will synchronize with the patient. And then we need to measure the next length, nose, ear and rectum. So how much length we have to put the catheter, that will come to know from this measurement. This is the multiplication, what will be the centimeter what we have to put the catheter is. This is if you are going through a laser, then the next value multiply by 0.91 and add 18 for 16 French, that is for adult. In oral it is 0.8. Yeah, the same test.
Just tell me what tube to put in.
Actually, patient can be intubated. It can be used invasively as well as non-invasively. This is just catching the triggering activity of the patient. Mass also, non-invasive also you can use. You can use normally also, only in the patient because they don't have any which are giving the signal treatment. If they are damaged, then we cannot use.
I think this will be the future of weaning patients.
Yeah, it can be
Spontaneously
used
breathe,
machine.
they've got a CL start or something like this. And that's where the adults have been using it, is less sedation, less paralytic. And they're letting it spontaneously breathe.
Yeah, in service. Not in service, in service.
It's much like we would have been using.